Good morning. Please join me in welcoming 3 distinguished leaders in occupational health. Dr. Michael Hodgson recently retired from federal service after leading occupational health efforts at OSHA and the VA with a career spanning academia, public health, and national policy. Dr. Melanie Hayes, a nurse practitioner with over 25 years of experience across diverse industries, now shaping occupational health policy at the federal level with a focus on collaboration and compliance. And Dr. Amy Behrman, professor at the University of Pennsylvania and longtime director of occupational medicine, whose career has centered on protecting healthcare workers through infection prevention and immunization programs. Together, they bring us a century of insight into a vital partnership. Please welcome them for today's presentation, 100 Years of Nurse Practitioner Occupational Physician Collaboration.
Hi, everybody. As we fumble around trying to figure out our tech here, thank you so much for the introduction. You're actually going to learn a lot about the 3 of us. Part of the structure of this talk is a discussion of where the 3 of us, how the 3 of us got to the point that we are now in our lives, happily collaborating, not only personally, but across training and professional lives. So we're here, completely different talk from that last wonderful discussion of museum occupational health to discuss physician-nurse practitioner collaboration in occupational health settings. Title of our talk, 100 Years of Nurse Practitioner Physician Occupational Physician Collaboration. I want to say, none of us have been doing this for 100 years. We may look like it, but together we actually have a century of collaborative experience, and we would love to share that with you right now. So, in brief, again, but with a slightly different twist, I am delighted and honored to be here with Dr. Michael Hodgson, who is now retired from OSHA, from the VA, from the CDC and NIOSH, and from academia. Dr. Melanie Hayes, who has been a nurse practitioner for more than 25 years and has done so in occupational health settings for more than 13. And myself, Amy Behrman, and I'm the fairly long-time director of occupational health for the University of Pennsylvania and Penn Medicine, so kind of an integrated system, a little different actually from what Dr. Fusco presented. Again, in brief, what we hope to do during the next 35 minutes or so is to outline the evolution of advanced practice nursing through the late 19th and, 20th and 21st century up to the present day, to discuss nursing practice, advanced nursing practice principles and resources, and then to present some specific examples of how this can play out in extremely positive ways in real life to benefit ourselves, but more importantly, our patients. So with no further rambling, I present Dr. Hodgson. And
Hi, Michael Hodgson. I have to see the slides from this, so, but I couldn't also see them. So I'm hold to it. Actually, in that case, I'm going to go and grab it. Oh, we don't have slides up here. I'm used to having slides in front of me. So the why does that not come? Right. So yes, this talk grew out of some of the controversy. Yes. This talk grew out of some of the controversy at APRN over the last 3 years. People know of the back and forth with nurse practitioners membership, and we thought it was worth outlining how those of us who have successfully worked with nurse practitioners recognize the relationship has fundamentally changed, then unless you recognize the change is permanent, you're going to be stuck. So, 83 to 91, I was in charge of occupational health at the University of Pittsburgh, wrote the employee health system where I backed up Paul Conti, a nurse practitioner who ran, all of the infectious disease stuff that we now think of as medical center occupational health. There wasn't any violence prevention. And I actually had a nurse practitioner who did my HADS work with Whopper reviews under a protocol. Then in Connecticut, we had 2 nurse practitioners who actually saw patients both for employee health and in the occupational medicine clinic. Then at the VA, we had a nurse practitioner in the central office, and there were nurse practitioners in many of the units around the country. And then finally, the last 11 years, we had 2 nurse practitioners towards the end of my term there, a mental health certified nurse practitioner who would come from the NIH who did our alcohol, suicide prevention, and the like, the recovery ready workplace program, and Dr. Hayes, who will talk about that a little more, the history of this a little more. So I just ran through the details, the important, no, there's no pointer. The important thing in this slide is there's an evolution in the way I, at least, very formally learned to work with nurse practitioners. And as in the 2000s, nurse practitioners nationally began working independently, the VA changed its credentialing process from the Office of Nursing to the credentialing thing for physicians at the hospital. So what happened at the VA along with that credentialing change? Nurse practitioners wound up reporting to the chief medical officer in process in the national office, and at the VA, nurse practitioners reported to the chief of staff and were credentialed by the medical board. At OSHA, when we decided to hire nurse practitioners, the question for people who know the federal hiring rules was, would they be hired as physicians, 610 job category under OPM, or occupational health nurses, a 602. There is no salary category for nurse practitioners, although OPM is working at that. And so the question for me as the office director was, how do I organize that work? How do I hire nurse practitioners to do the work that physicians do elsewhere, primary care practice, in a sophisticated office that does often high-end toxicology where people have not seen that kind of disease? And so we wound up developing a very formal credentialing process. Me as the office director wound up having to deal with that and writing in my personnel files. But more importantly, we developed a quality management process that was aligned with the VA quality management process, recognizing that only through quality management in the system could we ensure that the services we delivered met our standards. So there had been a QA process with quantitative stuff, categories, reports. We then wound up changing that when nurse practitioners showed up to what we think of as a formative evaluation process, where when a question came in, we would get consultation requests from the field. I would decide, is that a complex tox problem that goes to one of the interns? Is that really a pathology issue that would go to our pathologist? Or is this something that anybody could do because the research was not going to involve specific, sophisticated medical school type questions? And the first draft will always get circulated. And so all of the 6 physicians and eventually 2 nurse practitioners for 1 RN and LPN was an IH had input into those reports in an evolutionary way. So at the end, the credentialing process was a live, living way. And I think that's it. Dr. Hayes. It was the first nurse practitioner we hired, and Melanie, you're on.
Right, so let me just get my tech set here. When I began my practice as a nurse practitioner, you're going to see I was in the first class in 1999 that was required as a requirement for licensure, and to take the board certification exam, you had to complete a master's in science in nursing. So before that, most of the programs were certificate programs. You could complete the certificate program, take an exam, and be certified as a nurse practitioner. But around 1999, things changed and graduate level degrees became a requirement. So throughout my career, I'm going to outline that. I've lived through many of the changes that have occurred in the development of the NP role and where we are today. So we're going to talk about that. So when I began my practice in 2000, I was working in Florida in a rural health clinic, and I had a supervisory physician with a collaborative agreement. That agreement was regulated by the State Board of Nursing, but they said, you know, you have to have a supervisory agreement. So we had an agreement that outlined that I could be delegated tasks that included assessment, diagnosis and treatment of acute and chronic conditions, and certain classes of medications that I could prescribe. That continued throughout my career until 2012. I was under that type of a practice agreement. When in 2012, I joined the military system working for the federal government, and similar to the VA, I was in an independent practice role. So that looked a little bit different. I didn't have to have a collaborative agreement anymore, but there was a credentialing process. I had on-the-job training for occupational and environmental medicine with a board-certified physician in OncMed. She was fantastic. I learned a lot from her and from IH. There was an initial credentialing process with 100% peer review of my charts. And once she was satisfied that I met the competencies for occupational medicine, my chart reviews began to be 10 a month. And there was an annual credentialing certification of competency, both in my primary role as a family nurse practitioner and in my specialty of occupational medicine. And then, as Michael mentioned, in 2021, I joined OSHA, and he's described the process that basically we work under there. It is a very collaborative process. It's one of the best teams I've ever worked on. We really do have very positive and respectful collegial relationships, and I think that has influenced the results that we've been able to produce. We're going to be specifically talking about the NP role today, but I want to mention you may see a variety of initials behind people's names, from APRN to FNP-C and just things like that. When you see APRN, just know that stands for Advanced Practice Registered Nurse, and there are 4 different roles we'll talk about briefly about that. First, though, I want to give honor and respect to Dr. Loretta Ford, who is our co-founder of the nurse practitioner role. I saw her in the summer of 2024 at conference. She's still very spunky, very with it, and very much an advocate for the NP role. Unfortunately, she did pass away earlier this year at the age of 104. Her birthday's in December. So she was really something else. But she recognized a need for primary care services in underserved areas. And she knew the patients were not getting what they needed. And she really had this vision that she could train nurses beyond their traditional RN experience and training to have some advanced skills
and go in and fill that gap. So in collaboration in 1965 with Dr. Henry Silva, a physician, and Dr. Loetta Ford, a registered nurse, sitting here at the head of the table, who were both committed leaders from the School of Medicine and the School of Nursing. They came together to develop the first formal NP education programs at the University of Colorado. And this was a post-BSN certificate program. They put aside their long and strongly held beliefs about the dominion of their individual professions, medicine and nursing, and worked together to increase access to care. And that's really important, and I feel very passionate about that still today. So this program prepared pediatric nurse practitioners to provide health promotion and wellness, disease prevention, and manage acute and chronic conditions. And they actually set up child health clinics in the community, and they assess the economic, social, and physical conditions. So in this setting, the nurse practitioner was really important and stressed in the education programs that they knew what they were trained to do, and they recognized when a referral was needed, and they would refer back out to the physician or to other colleagues. Maybe there were economic needs. So they would refer out to other agencies in the community. Likewise, those agencies and physicians would refer children to the nurse practitioner. And collaboration and communication were really emphasized to allow people to perform optimum service at the level of their skills without overlap and duplication. This particular program was published in Pediatrics in 1967, and it is included in our references if you would like to go and read more about how that actually all played out. From the beginning, autonomy, collaboration, and accountability have been the bedrocks of NP practice. It's encoded in our ANA Code of Ethics for nurses, as well as in the scope of practice defined by the American Association of Nurse Practitioners. The NP role has substantial autonomy and independence and a high level of accountability. Collaboration, though, is an essential skill for the NP. Collaboration requires us to know our limitations and our skills and knowledge, to be aware of that, and to refer out as necessary, just as important as it is important for physicians to understand their limits in knowledge and skills and refer to specialists when appropriate. In 2011, the Institute of Medicine, now the Academy of Medicine, supported collaboration, communication, and systems thinking as the new basics for all nursing education. They also noted that multidisciplinary teams with respectful and extensive collaboration among those team members really improved quality, safety, and effectiveness of care. So as the APRN profession grew, as I mentioned, many of the programs were certificate programs. And the National Council of the State Boards of Nursing recognized there was a mishmash, and there were programs that were very specific in specialties that were training nurse practitioners. There were programs that were more generalist, and they felt a need to really consolidate and define the standard requirements for the education, competencies, and develop the certification exams for various roles. So they made recommendations about the scope of practice for APRNs. And this was called the consensus model for APRNs. If you're interested in reading it, you can obviously scan the QR code there. I'm not going to read it to you, but this is an excerpt from that, and I will give you a few key points. It identified the expectation of practicing within established standards, being accountable to patients and the nursing profession. That included complying with laws, as well as well-recognized standards of care. It emphasized understanding our limits in knowledge and experience and planning for referrals, consultation, and collaboration when our expertise was exceeded. I apologize for a busy slide. I took it out of the consensus model, but it really helps us understand, because again, we have so many initials after our names. We're going to start at the bottom, and just briefly, I mentioned there are 4 APRN roles: the Certified Registered Nurse Anesthetist, Clinical Nurse Specialist, Nurse Midwives, and Nurse Practitioners. So in order to be licensed in one of those roles, you have to have the basic education foundation in at least one of the population focuses. Now, some nurse practitioners will have more than one population focus. I've seen a lot of adult gerontology or family nurse practitioners who also took the program to be psychiatric mental health nurse practitioners, and they can be licensed as both, but you have to complete that basic education in one of the roles in one of the population foci. Once you have that, you have to pass a board certification exam, and then you can be licensed in a state. So above that, you'll see the specialties, and we're going to talk about that a little bit, because you will see sometimes nurse practitioners go on in a postgraduate program to get certified in things like palliative care or emergency nurse practitioner. So remember though, to be certified in a specialty, you have to have that basic degree, master's, postmaster's, or doctoral degree, and national board certification in order to enter practice. Those education and assessment strategies, those exams, are defined by the nursing profession, usually nursing organizations or professional specialty groups. The education can occur both at the same time as your primary role. So, for example, someone may be a family nurse practitioner and get their certification in emergency nursing. It doesn't have to be at the same time, it can be sequential. And competency is assessed by professional specialty organizations. So in 2011, the Robert Wood Johnson Foundation and the Institute of Medicine collaborated to issue the Future of Nursing report. And a few key points from that were they call for updating our scopes of practice, advancing our education requirements, supporting utilizing nurses to the full scope of their education and training. And also, it recommended independent practice for nurse practitioners. It called for all nurse practitioner education to be done through nationally accredited programs at the graduate level. And that was a broad-based generalist education with courses in advanced physiology, pathophysiology, health assessment, and pharmacology, as well as appropriate clinical experience. Once you completed it, you took a certification exam in the core role, and that certification does require ongoing certification of competency that can be done through a variety of means, such as continuing education and practice, or taking the exam again. So where do we stand today? At this point, a nurse practitioner has at least 6 to 8 years of education at the undergraduate and graduate level just to start practicing as an NP. The state boards of nursing regulate what nurse practitioners can do. They regulate whether there needs to be a supervisory or a collaborative agreement, or if there's full practice authority with independent practice. They regulate what prescriptions can be prescribed by nurse practitioners. And as of last year, all 50 states and DC allow nurse practitioners to now write for controlled substances. 87% of NPs are prepared in a primary care role, and 41% of full-time NPs have hospital privileges. That is also where that credentialing process comes in. We want to make sure that the person in that role is competent to do that. And many times hospitals will have a credentialing process similar to that they use for physicians to ensure that competencies are met. So This map tells us, again, where we are in that Institute of Medicine Future of Nursing Report recommendation for full practice authority for nurse practitioners. The states in green have full practice authority, and they are solely regulated by the Board of Nursing. Now, some of those states will have requirements for new nurse practitioners to operate under supervision for a certain amount of time or a certain number of hours before they're allowed to go into independent practice. Generally, these are in primary care roles, and I think that that's a good idea. I know I certainly benefited from having my own supervision and collaboration, especially in those early years of practice. The yellow states require a collaborative agreement that's not well defined, but basically it means you have some document that must be signed by a physician, and that is required for the nurse practitioner to operate. It doesn't say what must be in that collaborating agreement. The states in red have more restricted practice. This is what I practiced under initially in Florida. There is a supervisory physician requirement. And what we mean by that is not that the physician has to be on site supervising that nurse practitioner 100% of the time. They can be available by phone, but that agreement is much more prescriptive, and it's often described as delegating tasks that the nurse practitioner can do. And I'll give you an example. Mine was that I was able to do tasks that I was trained to do as a nurse practitioner. And then it also listed, like, I could order tests and physical therapy and things like that, but also the classifications of medications that I could prescribe. At the time that I was doing that, we could not run for controlled substances in Florida. So in conclusion, just coming back to this slide, I just want to say, I have seen a lot of changes in the NP role during my career, but the principles of autonomy, collaboration, and accountability have remained constant. And it takes a team to provide that high quality care. I've been very fortunate to work on some very dynamic teams, and I think we both benefited from each individual's expertise and knowledge and skills. And I'm going to now turn that over to Dr. Behrman to talk about some more specific examples of collaboration and issues that both primary care physicians and nurse practitioners who are coming into occupational medicine may encounter. And she will also talk about high-functioning teams that she's experienced. So, Amy, I'll turn it over to you.
Thank you so much, Melanie. Anyway, back up here again, and this time I am going to do my best to follow on those, to expand the themes, or at least focus on the themes of collaboration and teamwork, and how we can mutually benefit each other in collaborative teams, and more importantly, benefit our patients. So you're going to hear a lot about us, a little bit more about me. I have trained at Penn and had my first faculty appointment in internal medicine and emergency medicine, because it was so long ago that the emergency department was actually a section of internal medicine. Actually, it was a wonderful experience. And part of the wonderful experience was that in both the acute care settings, and then also in fast track, and also in our travel medicine areas, I worked collaboratively with wonderful nurse practitioner colleagues. So from really my first time as a attending physician, I was working in teams. This goes back to 1989. Because of the nature really of those settings, particularly in the emergency department, these collaborative practices did have direct clinical. The nurse practitioners were caring directly for patients. We were all caring directly for patients. We had established protocols to help guide both physicians and nurse practitioners through best practice cases, and that's been for those of you who are involved in emergency medicine, that's been a steady march towards the algorithms to support increasingly complex patient care. It also is a setting where immediate oversight or consultation was pretty much always available between the nurse practitioners and the physicians, just through the physical nature, the physical setup, and the clinical nature of the where we work. In 1994, I took a huge jump out of acute care and into preventive medicine and occupational medicine, also at the University of Pennsylvania. And at that time, we were pretty little, one clinic, one hospital, one doctor, two nurse practitioners, and that's what we did. And we cared for in-house for our healthcare personnel only. Based on that, leveraging the skills and the clinical resources that we had, we expanded over the next couple of decades to a much larger footprint involving 4 clinics at 3 hospitals in our downtown University of Pennsylvania health system. I'm going to say actually that we have a much larger system now, and we have colleagues, both physician and advanced practice colleagues at 4 outlying hospitals: Princeton, Doylestown, Lancaster, and Chester County. Some of those colleagues are here, and I think a large number of my colleagues from the downtown hospitals are here. I'm going to talk about our central core Philadelphia-based, hospital-based occupational health systems practices, which are primarily what Dr. Hodgson referred to as medical center occupational health. That is our main branch. At any rate, at this point, we have 7 1/4 nurse practitioners, a fabulous team, really the best team that I have ever worked with, and 3 physicians. I'm thrilled that all 3 of our physicians are here, Dr. Hassan Nizam, Dr. Sajad Sabul, and 2 of our nurse practitioners. Also, I don't know if you have met them, but Heike Wilson and Giovanni Del Vecchio are also here, so they can keep me honest as I go forward. So the nurse practitioners in our practices do primarily provide direct patient care with an independent practice, independent billing, collaborative model, consistent with our reduced practice state on the, our state is in a reduced practice state on the map that Dr. Hayes led. So how does that actually work for us? Our collaborative physicians are no longer required to be
Right here.
same time that a nurse practitioner is practicing, but we are always available.
Deal? You want online mute, please?
Not in person, easily available by phone and with a shared camera. The way we have set this up, and as Melanie quite correctly said, there's a lot of variation and room for interpretation in how you manage collaborative agreements. This is what's worked for us and what is working for us. The nurse practitioners really provide probably the bulk of the direct clinical care. We cycle in physician visits every 3rd or 4th visit for the longer cases, those that haven't been already resolved by that point, which of course is a real goal. And that cadence of physician and nurse practitioner encounters with a given patient for a single case can, of course, be varied depending on what the advanced practice nurse wants, what the patient wants, what the physician wants. But this pattern pretty much works for us to get people the care that they need and the best possible outcomes in terms of returning to work. Because we do this rotation, this model really facilitates an ongoing review. I can put it one way and say it facilitates an ongoing review of nurse practitioner charting by physicians, but the opposite is actually also true. We all see each other's notes and can learn from and also comment on and also contribute to each other's cases in a very dynamic and ongoing way, which I'm really grateful to be a part of. In our larger practices where the nurse practitioners are doing primarily direct care, I think they are absolutely recognized throughout the health system as superb clinicians who have tremendous patient satisfaction scores. The nurse practitioners drive some program development. I'll just give you one example. We have 2 nurse practitioners who really drive and manage our respiratory virus isolation and return to work programs for healthcare personnel. And that, of course, grew out of the COVID epidemic. I'm delighted that those two NP positions have remained funded, and we keep those people very busy. And they do a fantastic job. So, and then at our smaller sites, where there simply are fewer people, the nurse practitioners will do but quite a lot of the case management and have a larger role in hospital committees and program development, just because the division of labor is otherwise not possible. My clicker has stopped working. Sorry. Thank you, Scott.
Can you try it again?
To give you some examples of how collaboration and consultation work. But before I got that far, sorry, I'm getting my slides. I just want to say that, there's more to our lives than patient care and program development. There's also the professional satisfaction of groups like this. And I have just wanted to put up a few examples of organizations that I really treasure my membership in these organizations. And they are, in my opinion, wonderful examples of how professionals in our field, occupational health, collaborate across professional divisions. It definitely includes MARCOEM. I think we're all proof of that just sitting here. It includes the ICO, the International Congress on Occupational Health. It includes AOHP, a wonderful organization of primarily nurse-led, but certainly including physicians and APRNs that is primarily focused on healthcare workers. So they're not in that field, wouldn't probably be involved in that group, but it's a wonderful group otherwise. And finally, I just want to give a shout out to the Eagleson Institute and their colloquium, which is another fabulous group that collaborates for the care of laboratory workers across professional lines, including physicians, nurses, advanced practice RNs, and industrial hygiene and safety professionals. Just really a model of collaboration across what would, in some organizations, be harder. Thank you so much, Hassan, for what you just fixed. So I'm going to take just my last few minutes here and jump into some very concrete examples of how consultation and collaboration work in our practice. You probably feel like you know all too much about me at this point in terms of where I practice and what we do, and these are pretty much all real cases from it. So we champion the treatment of latent TB in healthcare personnel. And that is partly because we have lots of patients admitted who, as in that x-ray, have active TB, and we have the absolute goal of never letting any of our healthcare personnel develop a chest x-ray to the right of that slide. So we do a lot of latent TB treatment and try to be as proactive as possible about that. It's usually very straightforward, usually pretty easy to do. Here's a real case that has some complexity to it. A young mid-career physician with a recent conversion, who, as you have heard yesterday from Dr. Sowry and I think others, would be at increased risk of progressing to active TB if not treated. But this, you also have heard that the rifampin regimens that we primarily depend on for latent TB really can have quite significant drug interactions and lower the effectiveness of a number of important medications, including those in HIV PrEP. This individual, who lived with a partner who was HIV positive, needed to be on HIV PrEP, and the nurse practitioner who was seeing this patient tried first a non-rifampin rifamycin-based regimen, which was not tolerable to the healthcare worker, and then switched to a rifampin-based regimen but had really very significant concerns about how to manage PrEP at the same time. And for those two reasons, an internal consultation was made from the nurse practitioner to the attending physician so that we could go forward with this individual's preferred regimen. I'd love to talk about it more, but it's not really part of this presentation, so I won't. There are many, many examples where the nurse practitioners may properly and appropriately feel that they would like their patient to be seen by one of our physicians who may have more experience, in my case, perhaps decades more experience in a particular issue, such as latent TB. But other obvious examples are patients who are failing to progress despite state-of-the-art care from their nurse practitioner, those with medical complexity or fragility, and those who suffer unexpected complications. So that just kind of typical reasons that one of our team members might refer to one of the physician team members for ongoing management. I think the really important thing here is not so much the letter, this is really my theme, not so much the letters after our names, but our knowledge base and our comfort with a particular clinical situation. So really, always, in this, you're going to see this phrase over and over, it comes down to clinical judgment. And what's really important is not whether I know more about that antibiotic resistance in a particular patient with cellulitis, or perhaps Giovanni knows more about how to manage a patient who needs latent TB treatment. The point is us having the clinical judgment to know what we don't know and consult appropriately. Quite often that happens, most of the time that happens with them. But sometimes we need to go outside our. So here's just a couple obvious examples. 63-year-old medical assistant falls while performing some task at work and has non-radiating back pain or radiating back pain with plain films unfortunately demonstrating a lytic lesion and a likely pathologic fracture. A facilities technician with unresolving shoulder pain and weakness after a fall, for whom I or one of my nurse practitioner colleagues orders an MRI appropriately and discovers a large rotator cuff tear with retraction and a good surgical candidate, or perhaps a median neuropathy, which is not resolving with the non-invasive options that we have available to us in clinic. What do these people all need? These people all need an external consultation with a specialist. And that would be true if I was managing this patient primarily. It would be true if one of my nurse practitioner colleagues was managing that patient. This comes up all the time. Other obvious, I should say, frequent points of external consultation would be individuals with significant underlying pulmonary disease, orthopedic issues, like so many of the ones I presented on the prior slide, infectious disease issues, allergy issues. And in these cases, the decision-making and the clinical judgment, I would say, are identical for those of us physicians practicing in a primary occupational medicine role or for the nurse practitioners. The key point is clinical judgment, knowing when your patient needs a specialist outside your own practice and arranging that care to somebody who has the skills to meet their needs. And finally, talking very quickly, because I'm running out of time, I'm going to give you a couple examples of consultation from, in this case, physicians to nurse practitioner specialists. That's a stock photo, but just a nice one to illustrate that we have many healthcare personnel caring for extremely vulnerable patient populations. We had a topic nurse, this actually comes up all the time, with a distant history of anaphylaxis, who works in the ICN and might or might not be accommodated if they were not able to receive seasonal influenza vaccination. It's a real question. You do not want to do anything unsafe for this particular nurse. You do want to have him vaccinated with the protection of his tiny patients as well as himself. We have been fortunate up until the present time, sadly she just retired, to be able to consult a nurse practitioner who is trained in, who had extensive clinical experience, in infectious disease and also vaccinology and also allergy, who was able to facilitate or in many cases actually perform the allergy consultation and provide the clinical support to safely vaccinate some people in this scenario. And that has been just an enormous resource to our practice, and probably not only do most of the consultations come from physicians, they probably mostly come from me. So I'm directly grateful for that. Just one other different example, there are many specialist nurse practitioners in our system. One of the issues that we deal with quite commonly is complex needle sticks, not the straightforward ones where we can use the HIV post-exposure prophylaxis that Dr. Nizam presented yesterday, but ones where there is perhaps an issue with drug resistance, or in this case, not so much drug resistance on the part of the source patient as drug intolerance on the part of the treated healthcare worker, where we really need guidance from our ID colleagues for managing side effects and deciding on the best possible post-exposure prophylaxis regimen. And our first go-to for many years has been an ID-trained nurse practitioner in the HIV clinic who provides us with the next level of expertise. So in summary, I'm going to say that I think that in addition to being also, like Dr. Hayes, fortunate to be working with probably the best team that I have ever worked with, all of us can only function if we use our best clinical judgment. And I would say that that can be summarized as knowing when the patient needs expertise beyond our own, knowing how to find the right care for that patient, and finding the right consultant with the clinical strengths to address that patient's needs. So thank you for your patience and for my talking a little rapidly there. And really,
Thank you for this talk. I'm not in this field, but I'm just curious. Do you see like positive collaborations like this having any sort of impact on physician retention in the field and nurse retention in the field, especially lately with very real stress factors of people dropping out of the field for certain reasons? I would think this would share the load better and help people from a long line of nurses and the wealth of knowledge, just acknowledging it. Is there any impact, do you think, on just retaining people in both those professions?
am I live here? Yeah. So thank you so much for that question. I actually don't have to get it. I suspect that possibly my colleagues here do. But my personal experience has been very much that those positive relationships do actually keep people in practice and with perhaps less risk of burnout than they might otherwise have. And I'm going to say this, cite as evidence to that the longevity of the people in our own practices across there's all 7 of both the physicians and the nurse practitioners have tended to stay and improve it, but I suspect that is in fact part of the reason.
I would just add to that as Amy was talking, it reminded me of how seamlessly these interactions and this collaboration actually occurs in clinical practice. And I think sometimes we get caught up in the discussion up here where there may be some different opinions. But when you are in that high functioning team and you're working collaboratively, there's a good sense of a fulfilled purpose. I'm practicing to my ability. When I need consultation, I have that. And there are things that we can go back and forth with because we know each other's strengths and limitations. And it really is seamless when you're in clinical practice. And I hear this over and over again from colleagues, physicians, and nurse practitioners. It's like, what's the problem? Why is there contention? When we're in those teams and we're working, we're doing a good job. And that's when the patients benefit the most. And that's really, I think, where we need to come back to. Not only professional fulfillment, but are our patients getting what they needed? And I think in this healthcare environment, there's a lot of room for improvement and collaboration.
Well, I actually think the controversy was generated by some people who don't know what's going on in the world and worry about financial competition. I don't think there is a shortage of occupational physicians. There's a shortage of services for workers. So I think that the tension was made up, and people who were happy at work can't be happy at work, and having great partners to work with is clearly the thing that makes us all want to go back to work.
If there are no more questions or even actually have an announcement to make, all right with everybody here. One of my long-term longtime nurse practitioner colleagues has just retired, or will be retiring, has just announced that she will be retiring in January. We are posting as of now, one full-time position, one per diem nurse practitioner position. Anyone is interested or would like information? Talk to someone, talk to someone, talk to Giovanni.
Question.
Just because you're hiring now, and we're very excited because,
It's just
we know that, sure. That's an interviewing question, because you're not going to hire for new NP, find that person who also can function autonomously. And what would be a question, if I was thinking about your senior, I can already ask on an interview, if I was.
So I asked to answer this question in a different way because there is currently in the VA system an issue that has come up. So I happen to still know lots of people in the VA system, and where when nurse practitioners who had primary care practice authority became hospitalists, all of a sudden the complexity of their case management grew. And the point of that, and there was a complication that was unanticipated, leading to a major review at one of the flagship hospitals. And so things go wrong in any system. I think as we go through, we have to recognize that nobody is perfect. So the question then is, what's the goal of your interview question? Is it to find somebody to explore the breadth of the working with here? So is it red flag from back pain and recovery and something, or the complexity of patient care, patient satisfaction, and identifying satisfaction with the process of care rather than the question is a really interesting one, but depends a lot on the setting in which you're going to use the nurse practitioner and what all you can tell from that nurse practitioner's background and references.
I would say that one way might be to give a scenario and ask how that nurse practitioner would handle it. It will give you insight into their background, their experience, what they've done before. And if they don't, I mean, maybe they're very experienced in your scenario. You might say, well, what is the scenario that you might consider needing to refer to someone? And then that gives them an opportunity to, again, talk about what their skills are. I mean, it is baked into our education from the very beginning. You do what you're trained to do. We all have limitations in our knowledge. And so we have to know that, regardless of the letters behind our name. I think sometimes too, though, we all have blind spots. So having that initial credentialing process, that peer review of records, until there is comfort. I can tell you that the OCMED doc that I worked for in the Navy was one of the toughest docs anybody could ever work for. She was meticulous and she wanted it done exactly right. And she would not release you to do this specialty without feeling comfortable that she knew I knew what I was doing. And so over the course of a couple of weeks, we spent one-on-one time together. I would see patients. She would go in behind me. You know, there was one case where I found a perforated septum and she just was flabbergasted. She was like, no way. I've never seen one in practice. But there was a perforated septum. And so when she gathered that knowledge of working with me, she understood that, you know, I knew what I was doing. I knew when I needed to ask questions. And it's that relationship you're building on that team. So I would also ask about teams that maybe that person has worked on and
Yeah,
how
great
they
response. I was thinking of the exact thing, give a scenario and see are they referring to something very simple and asking the provider and they're not autonomous or they're appropriate.
Thank you very much to the panel.